The next presentation will be given by Paul Afolabi. He's from the University of Southampton. He has contributed significantly to the whole spectrum of 13C breath tests. He was instrumental in telling and teaching us about methodology, about performance, and he has provided us with contacts far beyond the medical field. I'm very grateful to Paul that he agreed to give a presentation at this meeting on sophisticated methodology and simple performance of 13C breath tests. Paul, please go ahead.
Thank you very much. My name is Paul Afolabi, and I would like to introduce today's presentation, which is 13C breath tests, sophisticated methodology and simple performance. So I would like to start introducing the concept of 13C stable isotope breath tests, which are valuable and non-invasive tests that can be applied for the assessment of gastroenterological symptoms and diseases. These tests also provide the opportunity to diagnose bacterial infection, such as Helicobacter pylori infection, and also to monitor pancreatic, exocrine, and liver function. And they also have the potential to be used in potential gastroenterological and non-gastroenterological applications. So the principle that underlines the application of 13C breath tests is that one or more natural carbon of the functional group in the substrate of interest, which is carbon 12, is replaced with a stable isotope carbon, which we call carbon 13. And this 13C labeled substrate is then given orally to the subject, and following the digestion and absorption of this 13C label, the 13C substrate is then metabolized in a rate-limiting step to 13CO2. This 13CO2 is then exhaled on breath in an amount that's related to the activity of the rate-limiting step that is taking place. So this slide here shows an overall picture of what the 13C breath test can be used, which is to assess various organ function in a non-invasive manner. And this slide here just summarizes what I've mentioned in my previous slide, which is the 13C substrate being orally given. And therefore, if the organ of interest, whether it's in the gut, in the liver, or in the pancreas, the 13C substrate is then metabolized, and the 13C label, which is designated in the blue triangle, then gets cleaved off the 13C substrate, and then is recovered on breath as 13CO2. So the rate of appearance of the 13C label on breath as 13CO2, due to the metabolism of the 13C substrate in either the gut, the liver, or the pancreas, is then measured in the mass spectrometer of what we call the continuous flow isotope ratio mass spectrometer, or the CFIRMS. So this slide just shows how we collect the breath samples that contains the 13CO2, and to the right of this slide just shows the type of mass spectrometer that we use. So basically, it's an automated system that analyzes the breath samples which we're collecting into the tube, and it measures the abundance, otherwise known as the ratio of carbon 12 to carbon 13 ratio in the breath sample. So over the past decade, many research studies have proposed the clinical utility of 13C breath tests. And this clinical utility involves the fact that the 13C substrate used in these tests kind of interacts with the metabolic pathway that's really relevant to the activity of disease. And therefore, it's assumed that the increased 13CO2 enrichment in the breath samples that we collect as 13CO2 indirectly reflects the change in metabolic function that is associated with the disease activity of interest. So this slide here just shows the overall vision of what the clinical utility of these breath tests are all about. Again, as I mentioned in the previous slide, it involves the oral dosing of the 13C substrate or metabolic probe of choice, which then goes through the metabolic pathway of interest, which is affected by the disease process. And if the metabolic pathway is affected by the disease, then the rate of appearance of 13C on the breath is then collected into the tubes, which is then analyzed in the mass spectrometer. And then you get a trace, which we can see at the bottom of this slide, where a graph shows the association between the rate of metabolism of the 13C substrate or tracer to 13CO2, which is expressed in the breath, with the severity of liver disease. And to the right of the slide then shows an example of where this whole different types of breath tests, how it can be packaged and how it can be used in real time to look at patients with different types of metabolic disease, such as in non-alcoholic fatty liver disease, which I will come to later on in my slides and explain a little bit further. So, current examples of 13C breath tests that has been used in clinical research are those which have been used to look at liver metabolism and also being used to assess chronic liver disease. And a few examples shown on this slide. For example, the 13C aminopyrin is used to look at cytochrome P450 activity or hepatic macrosomal metabolism, which is important in drug metabolism. Similarly, the 13C mefacetin is used, again, in the microsomal metabolism as well. And the phenylalanine breath test is used to look at the cytosol of hepatocytes, which is thought to be involved in fatty liver disease, both in alcoholic fatty liver disease or non-alcoholic fatty liver disease. And also finally, the 13C keto isocapurate breath test, which is used to look at hepatic mitochondrial metabolism. And other different types of 13C breath tests is also used to look at pancreatic exocrine function, particularly in patients with chronic pancreatitis. And the two breath tests that have been used is the 13C trioctinin breath test and the 13C mixed triglyceride breath test, which is based on pancreatic lipase activity. So there are also other 13C breath tests out there which can be used to assess metabolic dysfunction in the gut, for example. For example, the lactulose 13C urodide breath test is used to look at intestinal transit times and also gastrointestinal motility. The 13C sucrose breath test, for example, is used to look at the loss of enterocyte function or small intestinal bacterial overgrowth, which is very important in an ICU setting or in intensive care setting. The similar thing also applies to the 13C xylose breath test. And the last two in this screen below is the 13C dextromethorphan breath test, which can be used to look at the response to tamoxifen, which is used in the treatment of breast cancer, and 13C pantoprazole breath test, which is used to look at the antiplatelet efficacy of clopidogrel, which is used to reduce the risk of heart disease. So here in Southampton, we have been working over a number of years to use a type of breath test to use it to look at the assessment of non-alcoholic fatty liver disease. And this slide here shows an example of how we've tried to create a clinical utility of a breath test. And also this provides a clinical opportunity for us to see whether we can use 13C breath test as a potential non-invasive marker of liver fibrosis in patients with NAFL. Why in liver fibrosis? Well, because liver fibrosis is a significant clinical event during the development and progression of NAFL, which carries a significant burden to the patients. So normally, in the assessment of NAFL, liver biopsy is the gold standard that is used to in diagnosing NAFL, particularly liver fibrosis. So the question we wanted to ask is that, can we use this non-invasive 13C breath test as a surrogate marker of liver biopsy in patients with NAFL? So we decided to choose the 13C ketoisocapillary breath test. And the reason why we chose it is that is because the 13C ketoisocapillary breath test, otherwise known as 13C kicker, its metabolism is a test of hepatic inner mitochondrial membrane function. And the inner mitochondrial membrane function is a very important aspect of the mitochondria of itself, because in this site of the mitochondria is where you have your beta oxidation of long-chain fatty acids. You also have your electron transport chain system, or your oxidative phosphorylation. And you also have where you have a generation of reactive oxidative species, which has been shown to lead to oxidative stress and inflammation. All these three key features have been shown in many, many studies to be associated with the histological features and metabolic features of NAFL, such as in liver fibrosis and in type 2 diabetes. So in this slide here, to the left shows how the 13C kicker is being administered. So we administer the 13C kicker as an oral dose. We just mix it in water and we give it to the patient. And the 13C kicker is metabolized in the mitochondria of the hepatocytes, where it combines with coenzyme A. And when these two combine, there's an enzyme in the hepatic inner mitochondrial membrane called the branched chain keto dehydrogenase complex, where it breaks down 13C kicker to 13CO2, which we collect in breath tubes. So this allows us to measure how much changes is going on within the mitochondria during the progression of NAFL. So this slide here shows some of the results we got from using the 13C kicker in patients with NAFL. So we showed that when we assessed the hepatic mitochondrial function in healthy subjects and in patients in NAFL, which was stratified according to whether they had type 2 diabetes or not. And as you can see from the plot, where we plotted hepatic mitochondrial function against time using the 13C kicker breath test, we were able to show that there were differences in hepatic mitochondrial function in patients with NAFL with type 2 diabetes from patients without type 2 diabetes. And also there was a difference between the two groups when it was compared to healthy subjects. So this second slide here shows that when the patients with NAFL were stratified according to whether they had significant liver fibrosis or not, again, the plot on the left-hand side shows that the 13C kicker breath test was able to distinguish differences in hepatic mitochondrial function between patients with significant fibrosis from those who did not have significant liver fibrosis and from healthy subjects. So the overall summary from this presentation is that the 13C stable isotopic breath test are simple and non-invasive dynamic tests that can be used to assess changes in metabolic function that are associated with GI or liver disease activity. And also, 13C stable isotopic breath tests have the potential clinical utility to A, identify patients with GI or gastrointestinal and liver disease at a much earlier stage of disease progression. And also, these tests could allow for the monitoring of GI or liver function before and after clinical interventions in patients with chronic GI and liver disease. And finally, this slide here just shows the future of 13C breath tests in clinical research and hopefully in clinics across Europe, whereby if we can harness the clinical potentials of these breath tests, we can use it in a number of applications, such as in diagnostic assessment, where you can have patient selection, in monitoring, whether you can use it to indicate the toxicity or safety of an exposure, or to detect a change in the degree or an extent of a metabolic disease. Also, you can use this in a predictive manner to identify patients who, on the basis of their effects from a specific intervention or exposure, as I previously mentioned in the previous slide, or you can stratify patients by a prognostic assessment. Also, you can use it in pharmacological studies to look at the effect of an intervention on patients, and it can be used as an efficacy biomarker or a surrogate endpoint. And also, it can be used as a safety in safety assessments, where we can indicate the presence or the extent of toxicity related to an intervention or exposure. And finally, to be able to use it in risk assessment of patients, which allows you to indicate the potential for developing a disease or sensitivity to an exposure. And this is where I would like to finish the presentation. And thank you very much for listening to this presentation. Thank you.